Distinguished guests, colleagues, ladies and gentlemen, it is a pleasure to moderate this session on supporting self-care with a focus on sore throat. My name is Sabiha Essack. I hold a research chair in antibiotic resistance and One Health at the University of KwaZulu-Natal in Durban, South Africa, and I'm the chairperson of the Global Respiratory Infection Partnership. I'm also the vice chairperson of the WHO Strategic and Technical Advisory Group on AMR, and I'm really honored today to share the platform with my colleagues from the Global Respiratory Infection Partnership, Doug Burgoyne, John Bell, and Veera Taungrod. You're all very welcome. A few general announcements. This webinar is being recorded and live streamed via YouTube. The recording will be available on our website, as you see on this slide. You may ask questions using the question and answer box provided. Please feel free to slot in these questions as you hear each presentation, and we will take these questions at the end in the panel discussion. You're welcome to provide feedback also in the website that's stated there or at that email address. And please, we encourage you to become a member of FIP, again, using that website link there. Just to say that all of the information that we are in the video is confidential and cannot be copied, downloaded, or reproduced without the formal approval of FIP going forward. So those are just housekeeping announcements. We want to thank Reckitt in the UK for supporting this online program. This meeting is sponsored through an educational grant by Reckitt, who were involved in developing the program and topic areas. The views and opinions represented are those of the speakers and are not necessarily the views of Reckitt or FIP. So with those, great, sorry. Sorry, Chris. So this is our program for today. John Bell will discuss self-care in sore throat. Doug Burgoyne will discuss the symptoms and management of sore throat, and Veera Taungrod will present a case study of the management of sore throat in Thailand. This will be followed by a panel discussion and a question and answer session. I'd encourage all of you to please type up your questions in the Q&A box at the panel at the bottom of your screen. Those of you watching on YouTube, your questions will be posted into our chat, so please be assured that we will be seeing the questions that you pose for those watching on YouTube as well. So just a little bit about sore throat as a source of introduction. Sore throat is a typical symptom of acute respiratory tract infections that are more often than not of viral etiology and self-limiting. COVID-19 is also a viral respiratory tract infection with clinical manifestations ranging from mild influenza-like illness to severe pneumonia. Sore throat is one of the main symptoms of COVID-19, although it appeared to be underreported in the early stages of the pandemic and varied by region. In later reports, however, sore throat was found in up to 56% of patients in Japan, 47% of patients in Singapore, and 46% of patients in both Australia and the United States. Sore throat was more frequently reported in patients infected with the Alpha variant. We are all aware that non-severe COVID cases are managed by self-isolation, good hygiene practices, and symptomatic treatment, while at-risk populations are closely monitored for escalation to secondary bacterial infections. Sore throat is thus an ideal prototype for self-care or symptomatic management. The objectives of our session today are to list the presenting symptoms of sore throat, explain the diagnosis of sore throat, describe an evidence-based approach to treatment options, and describe the role that the pharmacists and their team can play in advising and educating patients and the public about sore throat. So it is now my pleasure to introduce John Bell, who is a practitioner or teacher in primary healthcare and professional services at the Graduate School of Health, University of Technology in Sydney. He's also the corporate relations consultant to the Pharmaceutical Society of Australia and principal advisor to the Society's Pharmacy Self-Care Program. John is a former national president of the PSA and president of the Australian College of Pharmacy Practice. He is currently a member of the Global Pain Faculty and of the Global Respiratory Infection Partnership, both international multidisciplinary groups established to address the issues of pain management and antimicrobial stewardship, respectively. This year, John was appointed the inaugural chair of the Australian Self-Care Alliance. Over to you, John.
Thank you very much, Sabiha. It's very much my great pleasure to be with you here this evening. Well, this evening for me, but I know it's very early in the morning in some places, in the afternoon elsewhere. So it's really great to be all around the world, I guess. So appropriate choice and use of treatments for sore throat. That's really my topic. I know that our other speakers, Virat and Doug, are going to talk about some of these issues as well. There'll be a little bit of overlap, but don't worry about that. That's more for emphasis. You can reckon on, if it's said more than once, it's really, really important. In fact, if we say it only once, it's important as well. So let's move on. Now, these are the disclosures. Most significantly, as Sabiha said, I'm a member of GRIP, the Global Respiratory Infection Partnership. Now, the sore throat, if we can go to the next slide, is our major topic of conversation today, but in the context of self-care. So what really is self-care? Well, the definition that WHO came up with in 2013 is this: the ability of individuals, families, and communities to promote health, prevent disease, and maintain health, and to cope with illness and disability with or without the support of a healthcare provider. That last phrase is really important because we can add so much more, that extra value to self-care, as one of the major healthcare providers. It's not just people looking after themselves, it's us helping people look after themselves. Now, Sabiha mentioned the Australian Self-Care Alliance. It's an organisation, a collaboration really, we've set up here in Australia just very recently. I'm honoured to be the inaugural chair. It's a collaboration amongst consumers of healthcare, of health charities, so consumer groups, health charities, policy experts, and industry groups. And we believe that self-care is an umbrella term to encompass not just individual responsibility, but responsibility for all of us. Now, you'll notice that WHO, in enunciating their definition, came up with these 7 pillars of self-care, and it's on the next slide. So knowledge and health literacy, mental well-being, physical activity, healthy eating, risk avoidance, good hygiene, and most importantly, what we're going to touch on, well, I will tonight, today, this morning, the rational use of products and services. But self-care is more than just individual action. It belongs as being embodied in health care policy in every one of our countries, but importantly for us as healthcare providers, it belongs in whatever we do, what the advice we give, the products we provide to our patients or our clients, whether they're self-managing ailments, whether they're minor illness, whether it's long-term or chronic conditions, acute conditions, or even major trauma. Self-care should be a part of everything we do and provide for our patients. So next there, Chris, please. Sore throat, as I'm sure we all recognise, is the most commonly first manifestation of the common cold. It's almost always a viral infection. Now, I know Doug's going to talk a bit about this later as well in somewhat more detail. Now, there are other causes, but they're much less likely. Strep throat is a bacterial infection, and maybe that accounts for 5–10% of respiratory tract infections, upper respiratory tract infections. Smoking is a cause of sore throat, whether it's passive or active smoking. Allergic rhinitis, particularly when we get that post-nasal drip down the back of our throat. And other forms of air pollution, whether it's petrol or chemical or diesel fumes, all can cause sore throat. But the most common cause is a viral infection. So antibiotics should have no place in the treatment of sore throat. Why do consumers want antibiotics? Well, they believe, erroneously, they believe that their personal benefits of using antibiotics far outweigh the personal cost. They're not so much interested in community cost, in community resistance to antibiotics. They think for themselves and their families, they're going to recover faster from the cold or a flu. They'll nip a cold in the bud. They think it's a cure for a bacterial infection, despite the fact that even if it is a bacterial infection, in that vast minority of cases that it's bacterial, it's a self-limiting condition. They believe antibiotics are safe. That's not always the case. We know that. They believe they're cost effective. They believe they'll get back to work or their children will get back to school or daycare more quickly. They recognise, increasingly they recognise that bacteria, the good and bad bacteria are killed by antibiotics, but they put that aside. They don't think that's all that important. They know it's a little bit more inconvenient if they have to go to the doctor to get an antibiotic. We know, though, in many cases, they don't need to go to the doctor. In some countries, antibiotics are available without prescription. They know it leads to resistance, but they think that's a small price to pay. So this myth about antibiotics being important is actually perpetuated. Why is that the case? Well, the next graphic, I hope, will demonstrate that. Doctors continue to prescribe antibiotics. For them, it's often the easy option. 90% of GPs, general practice physicians, believe that their patients want antibiotics for upper respiratory tract infections, for the treatment of a sore throat. Nearly half of all GPs have prescribed an antibiotic just to get the patient out of the surgery, just to finish the consultation. Sometimes doctors unnecessarily post-date prescriptions. They say to their patients, look, maybe you don't need an antibiotic, but if your condition, if your sore throat's no better in a couple of days, then take the antibiotic. It's a post-dated prescription. Also, if we can get back to that graphic, I hope we can soon. That's what I want to speak to. There are some countries, as I mentioned, where antibiotics are freely available without prescription. So we don't even have to go to the doctor. Now, I can't see the graphics there, Chris. I hope you can bring them up again for me. Otherwise, I'll have to go to my own computer to locate them. The other thing with respect to perpetuating this myth, non-prescription products.
Sorry, John. I'm going to try to share my screen, or shall I stop? Chris, shall I stop sharing? So, which slide are you on? I can try to share my screen.
I'm on slide 8, Sabiha.
Okay, give me one moment and I will try to get that done.
I know we'll get there, so don't lose heart, people. It's coming. Here we go. Thank you, Sabiha. So what I was saying there is that there are some non-prescription products that are promoted as containing an antiseptic, an antibacterial, or even some of them contain antibiotics. So this myth that antibiotics are useful or important or effective is perpetuated. So let's move on. Are you operating these slides now, Sabiha? If we can go to the next slide. So we mentioned that viruses are the most common cause of sore throat. What viruses are there? Well, mostly rhinoviruses, coronaviruses we're very much familiar with. We have been over the last couple of years. Influenza and para-influenza viruses, respiratory syncytial virus, adenovirus, and maybe there's 30% of viruses we don't yet know about that could cause the common cold and therefore that primary manifestation of a sore throat. Next, thanks, Sabiha. Now here's a graphic I thought I should put there. Sabiha's already mentioned COVID-19. We can't talk about sore throat or the common cold without mentioning COVID-19. It's with us, isn't it? It's everywhere. So what are the, I guess, definitive symptoms? Well, as I mentioned, with a cold, a sore throat is usually the initial manifestation. That's the first sign. We get a sniffle, a sneeze, maybe a runny nose as well. That can turn into a nasal congestion. Sometimes, of course, a cough. We may get a temperature, aches and pains, and fatigue. With COVID-19, we can have a sore throat, as Sabiha mentioned. Normally, that's not the first sign. Normally, it's a fever, a new persistent cough, and a loss of taste or smell and shortness of breath. And the graphic down the bottom of my slide there indicates that the NHS in Britain put out this graphic. If you have any of these symptoms, self-isolate and get tested. High temperature, new persistent cough, loss or change in sense of smell or taste. But we know any of the symptoms that we've listed here, if they come on suddenly, go and get tested for COVID-19. Now, the Times of India, on the next graphic, thanks, Sabiha, put this a little bit differently. Their source was WHO and the Centre for Disease Control in the US. Their graphic indicated what I've just said, really, that sore throat, stuffy nose, runny nose, sneezing, most likely indicative of the common cold. And you can see with COVID-19, dry cough and fever, the predisposing symptoms. Influenza, you can see there the most common symptoms that we're likely to encounter. Thanks, Sabiha. What's the impact of the common cold? We know it's pretty significant. It's not considered life-threatening, but the symptoms still cause discomfort. And what we aim to do is treat those symptoms. We're looking for good, effective, symptomatic relief. Normally, the symptoms clear up on their own. They are self-limiting symptoms, normally 7 to 10 days, but some may last, the cough particularly, for 3 weeks or more. Now, the fact that the symptoms usually last 7 to 10 days is important when we consider that doctors often say, look, you might need an antibiotic if you're not better in 2 or 3 days. That is bad advice. We don't need an antibiotic after 2 or 3 days. We continue with our symptomatic treatment. Frequency, well, we know young children suffer more frequently, young adults 2 or 5 times a year. As we get older, we get some kind of immunity to the cold and therefore don't suffer sore throat quite so often. But there you can see how many times on average a person suffers the common cold in a lifetime and the number of years we suffer. Now, what is the underlying cause of a sore throat? It's actually inflammation of the airway. Local symptoms, specifically sore throat, sneezing, runny nose, nasal discharge, congestion, and so on, associated with inflammation of the airways. Some of the systemic symptoms are associated with the release of cytokines from the leukocytes. You can see those symptoms there. In any event, anti-inflammatories are the first line treatment. Thanks, Sabiha. Next slide, thank you. Now, I put common cold treatments and sore throat treatments into my favourite search engine the other day. This is what I came up with. There are many, many more treatments they recommend, dozens and dozens more. These are the ones that maybe have a little bit of evidence about them. At least they can't do much harm. But what about the evidence-based treatments that we can recommend? I'm hoping in the next graphic we'll see them. Here they are. This is something the Global Respiratory Infection Partnership, Vera, Doug, Sabiha, myself and the rest of our team put together in differentiating the various treatments and their benefit. So we know oral NSAIDs, they relieve pain, they have an anti-inflammatory effect. Other analgesics, maybe not so much an anti-inflammatory, but they do relieve pain. The local NSAIDs, I'm thinking of lozenges, throat sprays containing an anti-inflammatory. You can see they have a broad effect of a targeted action. They relieve pain and inflammation. They have, importantly, that demulcent effect. They're soothing for the throat, and they have very, very few adverse effects. The local NSAID sprays or gargle are very effective as well. Maybe they don't have that demulcent effect, but the other benefits we can get from them also. Anesthetic or antiseptic lozenges are often useful. And sometimes, of course, we get a combination, don't we, of lozenges containing maybe an anti-inflammatory, maybe an anesthetic as well. So you'll see there a range of treatments available and how we can choose one or other, or maybe a combination, maybe a pain reliever and an anesthetic or anti-inflammatory lozenge or spray to treat the specific symptoms, to personalise the treatment for the most problematic symptoms our patients are experiencing. Thank you, Sabiha. What challenges do we face? Why do we face rather? Why don't we as pharmacists intervene more frequently? Why don't we recommend symptomatic treatments? Why do we allow people to perpetuate this myth about antibiotics? Maybe we as pharmacists don't have sufficient understanding of upper respiratory tract infections. Maybe, I think, often there's an unwillingness by us to differ with our doctor's recommendation. We don't understand the alternatives that are available, the more appropriate alternatives. Maybe there are financial disincentives if we don't dispense antibiotics or don't send our patients to physicians to get an antibiotic prescription. Maybe we don't get enough support from our global or national organisations. Well, that's certainly changing, particularly with today's webinar. We're getting lots and lots of support from FIP, and soon we're going to get a publication from them as well, enunciating all of what we're discussing. We need to provide realistic expectations for our patients. So sore throat may last a week or so. Continue with that symptomatic treatment. You can see the other duration of the common symptoms of upper respiratory tract infection. What about the red flags? What about risks? Well, I'm sure if someone comes into your pharmacy or is in your hospital coughing up blood, really, really short of breath, we're not going to give a symptomatic treatment. We're going to refer them to the medical practitioner. But there's some other things we should be aware of. Very high temperatures, great difficulty in swallowing. Difficulty in swallowing is a symptom of sore throat, but if we're unable to swallow food, that's more serious. Unilateral neck swelling, unrelated to lymph nodes, drooling or muffled voice, wheezing sounds when breathing, or if all these symptoms, even the milder ones, last for more than 2 weeks or getting progressively worse, we should be referring. Thanks, Sabiha. So in summary, recommend symptomatic treatments for relief and allow for personal preferences. Target the main cause of discomfort, that is to reduce underlying inflammation. Choose topical therapies when appropriate. Lozenges containing anti-inflammatories like benzidamine, flurbiprofen, lignocaine perhaps. I've got a graphic there of it was a lozenge. Maybe it's not so much available now with cocaine and menthol and eucalyptus. Perhaps someone was sniffing it rather than sucking it. Now, I'll just leave you with this. It's a little poem that a guy wrote back almost, 60 years ago. I love the doctors. They are dears, but must they spend such years and years investigating such a lot of illnesses which no one's got when everybody, young and old, is frantic with the common cold? And I'll eat my only hat if they know anything of that. Well, we know much more about it, don't we? We pharmacists can triage people with sore throat. In the vast majority of cases, we can treat with appropriate products and the very best advice. Thank you.
Thank you very much, John. Sorry about the technical glitches there, but I hope we managed to get the messages across. So I see one or two questions in the Q&A, and I think that there are a few more in the chat as well. Please continue to write up these questions as the presenters go through their presentations, and we will have a panel discussion in the end. Chris, I'm going to just introduce Doug, and then I'd like for you to share your screen because it's difficult for me to monitor the chat while I'm sharing mine. So just to introduce, sorry, one moment. There we go. It is now my pleasure to introduce Doug Burgoyne, who is currently Adjunct Associate Professor at University of Utah College of Pharmacy. His previous roles at Veridicus saw Dr. Burgoyne manage clinical pharmacy functions and programs alongside disease management for self-funded employers. In addition, Dr. Burgoyne is a member of the Global Respiratory Infection Partnership, or GRIP, past president of the Academy of Managed Care Pharmacy, and a founding member of the Utah Aware, an antibiotic resistance education program for the state of Utah. As a leader of this organization, Dr. Burgoyne was influential in reducing inappropriate antibiotic use in pediatrics and adults through public awareness campaigns and physician education programs. Over to you, Doug. I will just wait for Chris to share his screen.
That's great. Thank you, Sabiha. It's a pleasure to be with everyone, and we'll get our slides here up in just a moment. While Chris is bringing our slides up, I'd like for you to think about what we just heard from John about a presentation of sore throat at your pharmacy. How many times have you had someone who comes into your pharmacy counter and says something like, "Oh, geez, doc, I've got a sore throat. What can I do about it?" Or you're at home during cold and flu season and your neighbor or a family member comes to you and says, "I think I've got a cold, but I need an antibiotic to fix it." I think that happens all the time. Hopefully less now than in the past, but certainly it's still a common problem where folks believe that antibiotics are going to help them when really we know that they won't most of the time. My portion of our presentation today is to talk about the presentation of sore throat, to build on what John has given us related to self-care, and differentiate bacterial versus viral infections, and how you in the pharmacy can contribute to the appropriate diagnosis. So the learning objectives, let's go back one slide, one sec. Learning objectives today are, thank you, are to present the symptoms of a sore throat. John has given us a brief sketch and we'll go into a little more detail. Then the diagnosis of sore throat, an evidence-based approach to treatment options, and then the role that the pharmacist can play as well as the pharmacy team can play in advising patients and educating the public about sore throat. So the presentation, as we said, imagine yourself at the pharmacy and someone comes up to your pharmacy counter and they're telling you that they have a sore throat, that it's been there for a little while, and they just worry because they don't want to be spreading illness. They're worried about their children, whether they might get it. Or on the other hand, it's not an adult. Instead, it's a pediatric patient. And that pediatric patient needs help as well. Sometimes schools tell their students that if they have sore throat, they should not be in school. So a parent comes to the pharmacy for a prescription of an antibiotic to cure that sore throat. Well, what are the signs and symptoms that a pharmacist should evaluate when thinking about the clinical presentation? First is a sore throat or a soreness in the throat that worsens when swallowing. There is some regional lymphadenopathy that may cause some neck pain or some swelling. And there is also cold symptoms such as fever, headache, or fatigue that might accompany that sore throat. Now, it's important to differentiate the fever and the fatigue from bacterial versus viral infections. The fever is generally low grade when it's a viral infection, and much higher grade fever in a bacterial infection. So that's an important distinction right there that we should be considering when someone presents at the pharmacy. Let's go to the next slide and talk about the difference between bacterial and viral infections. As John mentioned, bacterial infections cause about 10% of sore throats worldwide, perhaps a little bit higher in less developed countries. The most common bacterial infection associated with sore throat is group A strep, or GAS. GAS often presents with some of the same features that we just talked about with the most common causes of sore throat, which include fatigue and sore throat pain, fever as well. But generally, fever associated with a bacterial infection is faster onset. So it's a rapid onset fever is a sign of a bacterial infection compared to a slower onset, mild, low-grade fever that's generally caused by a viral infection. Now, the concern that physicians have with bacterial infections is that they can lead to some pretty nasty consequences. For example, sinusitis, otitis media, or, heaven forbid, meningitis. So sometimes physicians who are wanting to satisfy a patient, as John said, will prescribe an antibiotic with the justification that they're preventing secondary infection and that they are trying to cure any potential bacterial infection to avoid the consequences and sequelae of a bacterial infection. Well, that's a noble cause and certainly important, but it's just as important, in fact, more important perhaps, to be able to distinguish and confirm whether a patient has a viral infection or a bacterial infection. And we'll talk about that in just a moment and what the pharmacist can do. So viruses cause 80 plus, 90-ish% of all sore throats. Those viruses, as John mentioned, include rhinovirus and the flu A and flu B, and then some non-infectious causes as well. As we in North America turn into winter time, we recognize that in the city where I live, we have this inversion, or because we live in a valley, cold air gets trapped in the valley and warm air sits actually above it. When that happens, all of the exhaust and the pollution that is caused by industry and cars and our daily living gets trapped. That air becomes really, really nasty and is a common cause of sore throat. So the presentation at the pharmacy counter of sore throat is something that a pharmacist should go through, considering what the etiology is. Is it a viral infection, bacterial infection, or no infection at all? Well, are antibiotics necessary? Generally, even though they're not, 60% of the time, antibiotics are prescribed for sore throat. We're at John, Sabiha, and some other Global Respiratory Infection Partnership colleagues of ours. We're happy to submit an opinion paper to the journal Antibiotics in 2020, where we identified some of the things that we'll be talking about today. And we were astounded that 60% of patients with sore throat receive an antibiotic, and that's probably underreported. However, 90% of patients recover within 1 week without an antibiotic. So we know that if someone is not prescribed an antibiotic and there's not a confirmation of a bacterial infection, then probably symptoms will resolve within 7 days. So how can the pharmacist be involved in that differentiation of bacterial versus viral infections? And that is, well, the answer is point of care testing. Point of care testing is something that is proving to be very successful and efficient in the pharmacy. It accurately diagnoses group A strep, which is very difficult sometimes to distinguish all on its own. In fact, there's a study that's performed that a clinical presentation of group A strep has some of the least sensitivity or accuracy around appropriate diagnosis, where a point of care test can be tremendously accurate. Point of care testing is available worldwide, and the results are available within just minutes. Think about a strep culture when you go into the physician's office. There is a rapid strep test that can be done in about 15 minutes with lower sensitivity, or culture that takes a day or so to grow. By then, the patient has left the clinic and probably has an antibiotic in hand. There is the watch and wait method of prescribing, where a physician says, hang on to this prescription, don't fill it yet, but fill it in 7 days if your symptoms are not relieved. However, even that results in inappropriate antibiotic use. In fact, how often, I wonder, and maybe you know from your practice, does a patient still fill that prescription that was intended for watchful waiting because they just want to have it on hand in case it becomes a bacterial infection? I think it probably happens quite often. So, what are the benefits of point of care testing? Well, in the pharmacy specifically, point of care testing benefits to the patient are that it can be done anytime that the pharmacy is open. It's lower cost than going into a physician's clinic, and it's quicker than getting an appointment with a doctor. The benefits to the pharmacy are that you get to have increased interaction with your patients, and it's more of a clinical role instead of a dispensing role. Pharmacists become more of a healthcare provider to their patients instead of just a dispenser of medicine. And there's the opportunity for increased revenue to community pharmacies. So all of these are enhancements to the practice of pharmacy in your community. Now, we've said that most of the time, sore throat does not need an antibiotic, but that's not always the case. So when should you refer your patients to a physician? First, if there's difficulty breathing or swallowing, if there are any signs of an upper airway obstruction, if there's any blood or phlegm in the saliva, dehydration or rash, joint swelling or pain, or if there's no improvement within 7 days, then that's the time when we should refer to a physician and get their input. And thank you very much. That's the conclusion of my portion.
Thank you, Doug. That was really good. And it's good that you spoke about the point of care testing and the importance of differentiating between a bacterial and a viral infection to inform the need for antibiotics. So thank you very much for that. I do see a few questions in the Q&A, and I think some of them are being answered in writing. We will take a number of these at the end, so please continue to write up your questions in the Q&A box, and also I think there might be a few in the chat as well. So I'm going to introduce the next speaker and then hand over to Chris to take over in terms of the slide sharing. So it is now my pleasure to introduce our final speaker, Dr. Virat Tongrod, who is the Vice President of the Pharmaceutical Association of Thailand under royal patronage in Thailand. He's also the Vice President of the Thai Community Pharmacy Association and the Thai Drugstore Club, and has several leadership roles in the subcommittee of the Accreditation of Pharmacy and the Executive Committee of the Thai Pharmacy Council. You're very welcome, Virat, and we look forward to your slides.
Thank you, Sabiha. Nice to meet you and nice to meet everyone around the world. Next slide, please. For me, I will present you all about the case study for supporting pharmacists in the community pharmacy and to help the patients to handle when they get sick from the sore throat. In Thailand, the majority of the people, when they get sick, they seek help and advice from community pharmacy because these community pharmacy locations are convenient to access long hour operation and have a reliable healthcare professional, have a pharmacist on duty. To support these community pharmacists to help patients with sore throat. Next slide. First, co-work with the RB in Thailand to develop these leaflets we call self-diagnosis on sore throat. This use the concept for modified Centaur score, or we can call another name Essack score. It looks like a checklist and check depend on sign and symptom of the patient with sore throat that can check tick and cumulative to be the total score from -1 to 5. This checklist is a form criteria from just like a fever more than 38 Celsius or absence of cough or no cough, and the enlargement of the anterior cervical node, and tonsillar exudate and swelling, and the age of the patients. And we have an example of the picture of the sore throat. It's shown in the left side. This picture contains two small pictures. The left part is show the sore throat that infect from viral infection, and the right part is the picture of the sore throat that infect by bacteria. It's used to explain, to consult and educate patients that their sore throat is from viral or bacteria. And this leaflet help pharmacists to educate people to create awareness, and they understand their symptoms, and also educate use of antibiotic. Next slide. Second, we design a toolkit called Self Sore Throat. This toolkit is developed from the Community Pharmacy Association of Thailand. This toolkit, the main is have a mirror. That when people come to the pharmacy, they often ask what it is used for. So this will help us very easy to start present them that this mirror is for see your throat. If your throat are suffer from viral or bacterial infection, also we have a picture that have viral in the left side and bacterial infection of sore throat in the right side, and also we have a light and the leaflet, and also we have the tongue pressure that is good for present and consult and advise patients. Is a good. Next slide. And also third, some patient or some people want to see their throat, or some people let us see their throat that they take a picture from home. So I developed this mobile application for patient self-diagnosis on sore throat. We call HCU sore throat. This application is like a co-work from the Faculty of Pharmacy and Faculty of Science and Technology, หัวเฉียวเฉลิมพระเกียรติ University. And also, we have patient fund from GRIP, Global Respiratory Infection Partnership, and RB Thailand. This application have 3 major functions, as you see in the right hand. Toast scan, Essack score, and patient leaflet. When you click the toast scan, next slide, it will appear like a left picture that you can camera or take a picture. And if you take a picture of the patient sore throat, it will appear in the right part of this slide. The above is a picture of the patient throat, and below is a standard picture that we can consult or educate the people that her or his sore throat is infected from virus or bacteria. Next slide. And if you click the Essack score, it will appear like a checklist that we can see from the leaflet. You can click depend on the symptom of the patients. Such as in the middle, you can see if the patient have fever more than 38 Celsius and no cough, and that tonsil have exudate or swelling, and no enlargement of the lymphatic node in the neck, and the age of the patient is over 45 years. When you click summary, the score will show that only 2, and it's no need to use antibiotic in this case. Next slide. This T program or T platform help the pharmacists in Thailand to handle patients with sore throat. It's very good and it's very well accepted from the pharmacist. And next, I want to present you a survey or a study. A survey is about 8 years ago, and it's published in the Journal of Health Research System Institute of Thailand. This research the objective is to compare the patient health outcomes and satisfaction between the 2 groups of antibiotic dispense group and non-antibiotic dispense group after visiting Thai community pharmacies. Next slide. Next. In this study, we have patients with sore throat, 714 patients with sore throat come to pharmacy, and pharmacy may dispense or not dispense antibiotic. After that, about 3 or 7 days, we call back to the patients and ask them on two issues. The first one is what the outcome of the patients, and the second one is the satisfaction on this visiting. Next slide. Next. When we collect the data from the 714 patients and analyze to the first result, patients' health outcome, you can see the red color is an antibiotic dispense group, and the gray color is non-antibiotic dispense group. we ask them 3 outcomes: not better, better, or fully recover. You can see that the majority of the patients, whatever there has been dispensed antibiotic or not, the recover and better is the majority of the patients. Next. When we have statistical analysis, we found that in both groups, there are no statistical significant difference between the both groups. That means that for antibiotic dispense group and non-antibiotic dispense group, the outcome after visit pharmacy with the sore throat is the same. Whatever they had been dispensed antibiotic or not. Next. And also we ask our patients about their satisfaction on pharmacy service. And we found that majority of our patients with sore throat very satisfied of the pharmacy service. And when we analyze the statistical significance, it shows that no statistical significance between both groups. That means that, or can conclude that whatever the patient with sore throat dispense or get antibiotic and take it, or not get antibiotic, the satisfaction of both groups is the same. Next slide. From this study, it shows that the same outcome and satisfaction for antibiotic dispense group and non-antibiotic dispense group. And it means that antibiotic is no need for sore throat in the majority case, but we must to consult the professional to help each patient that it needs antibiotic or not. Next slide. And also in Thailand, we have like a Thai herb for sore throat. It's named Endogaphyt paniculate or cleat or green charlotte, or in Thailand we call Pha Thalai Chon. This herb had a traditionally been used in India, China, Southeast Asia, and in Thailand for common cold. But for in Thailand, Endogaphyt paniculata is used for sore throat, common cold, influenza, and acute diarrhea. This herb is listed or approved in the National Drug List of Thailand since 1999. The recommended dose is to take 1.5 gram 4 times a day, and it's effective. It's good. Next slide. And this document or research paper that show that efficacy of endogaphic paniculata for pharyngotonsillitis in adults, that published in Journal of Medicine Association of Thailand 1991. You can search and see. Next slide, the picture of the Pha Thalai Chon in Thailand. And for the COVID, we found that this herb with the higher dose is effective to treat COVID patient with mild or no symptom. In fact, COVID symptom is good for COVID too. These are on my presentation about the case study of the sore throat in Thailand. Thank you.
Thank you very much, Virat, and congratulations again on this very innovative way of determining whether sore throat really requires antibiotics or not. I'd like for us to, Chris, if you could stop sharing the screen, and if all of the speakers could please put their I don't need to say anymore. If you put your mics and your cameras on, we're all good to go. We've had a number of questions. I'm going to start with the two specific ones for Dr. Tomrat, Virat. We've got two questions in the Q&A directly for you. And the first one relates to what type of feedback did you receive from the patients on the mobile app in terms of its usability and its usefulness for the diagnosis of sore throat? So over to you, Virat.
Feedback for mobile application is very good, especially in the young people. And the pharmacist is happy to use it to take a photo of the patients, because it's not easy for the patients to self photo. It's not easy to see the sore throat line. We can help them and photo it, and you can compare with the standard picture. It's easy to advise or consult the patient, and can educate them, give them the awareness of antibiotic, and show that the majority is sore throat is infected from viral infection. Nearly 80 or 90% in adult in Thailand is found like that.
Thank you very much. We had one or two questions in the chat related to the symptomatic management of non-severe COVID patients. And just to say that COVID-19 is a viral infection. Yes, it can range from the mild flu or flu-like symptoms, which are symptomatically managed, and it can go as bad as requiring ventilation and intensive care therapy, etc., within the hospital. In the chat, in one of the questions that we've responded to in writing, I've put in a link to the BMJ live updates of treatment options for COVID-19, and it gives a very nice overview of what evidence-based treatment there is for COVID-19 patients. So in the non-severe cases, it is still purely symptomatic, analgesic, whatever symptoms patients come up with, we try to do the symptomatic management. And then if it becomes serious, where there is a secondary infection, obviously informed by microbiology investigations, we would recommend an antibiotic. And then in terms of the way in which the disease progresses, there are a number of options in terms of treatment of the more severe and critical forms of the disease. So this is a question for everybody, and this is perhaps something that we all grapple with in our situation, in our practice. Many pharmacists across the world provide antimicrobials over the counter, antibiotics over the counter. The question is, how can we convince patients that they do not need antibiotics, where a refusal in one pharmacy would just result in the patient going to another pharmacist, who would then be very happy to give them the antibiotic. So what are some of the interventions or ways in which that we could stop that? So anybody of the panel, please, who would like to go first?
I'm happy to start off,
Thank you,
Sabiha.
John. Please go ahead.
I haven't got an easy solution, though, I must say. This is very difficult, and we know that various national organisations and certainly global organisations like FIP have been advocating for stronger regulatory controls, a stronger regulatory framework in all countries that would restrict antibiotics to the most appropriate conditions. And of course, that would mean never having them freely available in markets, in non-pharmacy outlets, and only in pharmacy under strict conditions, usually on doctor's prescription. So that's not easy. That's a big challenge for us. But from a national point of view, if you're working in a country where antibiotics are freely available, then I think the very best thing you can do, apart from trying to get FIP to help in your country, is go to your own government, to your health department, and advocate strongly for better controls. It won't be easy to do, but it's really, really important that a strong regulatory framework around the availability of antibiotics is put in place.
Thank you. Doug or Virat, would you like to add anything to John's response?
Yeah, I think it's the responsibility of all community pharmacists to work together and have the same response. As you mentioned, when there's pressure on a pharmacy to sell something, whether it's an antibiotic or a symptom relief therapy, then the incentive is the sale and a satisfied customer that comes back to your store. And that's a pretty big incentive. So if every community pharmacy in the area can join together, and you can work with your neighbors to say, a neighbor pharmacist to agree to tell patients that because antibiotics don't work, then that nobody in the area will be dispensing them, then it can have a real community impact. There's also the point of care testing. And if you have that available in your pharmacy, then you can show the patient that they have a viral infection and that an over-the-counter symptom relief therapy be the most appropriate treatment.
Thank you, Doug. And I see some comments in the chat to say that not all countries allow antibiotics to be supplied over the counter. I completely agree with you. The vast majority of countries do have regulations that require antibiotics only to be dispensed on the prescription of a medical practitioner. However, we do know that this happens despite the regulations. Many countries don't have the enforcement capabilities. And just to say that in some countries, like mine in South Africa, pharmacists are allowed to prescribe antibiotics from the primary healthcare formulary, but provided that they have undergone a training course, which we call the primary care drug therapy training course. This really speaks to incorrect practice and unethical practice. And Doug, you're quite right in that it really calls upon the professionalism and the work ethic of the pharmacists, and perhaps pharmacists in a particular community, in a particular region, getting together and saying, we are going to ensure that we have efficacious antibiotics for all of us for the future, and all of us commit not to prescribe an antibiotic unless absolutely required based on point of care tests or prescribed by the practitioner. So thank you for that. I have a question from the beginning that's, again, a general question to everybody. How can a pharmacist, specifically a pharmacist, play a role in the awareness of the appropriate antimicrobial use? And the person has asked that you draw on your own experiences as to how you participated in an awareness campaign. I think, Virat, you gave us a really good example of an awareness campaign. So I'm going to not ask you this question. Perhaps John and Doug, would you like to give an idea of what campaign you participated in? Go ahead.
You go first, Doug.
Yeah, happily. We created a program called Utah Aware, which was an antibiotic awareness program for our state in the United States. And the first thing that we did is we went to the prescriber community and we said to prescribers, physicians, nurse practitioners, physician assistants, et cetera, we asked them a question. What do they need to support their decisions with their patients to not prescribe an antibiotic? The pressure that a physician has to prescribe is very similar to the pressure that a pharmacist has to dispense in places where an antibiotic is not necessarily required. So physicians said, we know when someone has a viral infection most of the time, and we can differentiate viral versus bacterial the majority of the time. But the patient still wants an antibiotic, even when we've told them that it's not going to work. So teach the community. So that's what we did. We followed the council of the physician and the prescribing community, and we created a public awareness campaign where we educated the community about viral versus bacterial infections. Similar to Wheerott's campaign, we incorporated signage on billboards. We had public service announcements on the radio. We had newspaper advertisements that talked about the difference between the two and the lack of efficacy of antibiotics in a viral infection. And it was effective. We measured azithromycin utilization as well as doxycycline and some other antibiotics during that time period. And we saw that the use of antibiotics decreased from one cold and flu season to the next. And we tried, of course, to manage for all other confounding influencers. But we were gratified to see the reduction in antibiotic prescription utilization. And then the second thing that we saw was that the sensitivity to antibiotics and resistance was improved. So the resistance to azithromycin decreased in just 1 year. And it was a pretty significant impact. So it can work and it can be effective in local communities.
Thank you, Doug. John, over to you.
Yeah, thanks, Sabiha. Yes, like Doug, we've had some local and national campaigns in Australia. The Commonwealth Government in Australia has funded an organisation called the National Prescribing Service to produce materials and advertising materials for pharmacists and doctors and advertising to consumers to make us all aware of the benefits of symptomatic treatment for sore throat and cough colds generally, and the inherent adverse effects and dangers of inappropriate use of antibiotics. So that's worked pretty well. And as Doug has mentioned, in Utah, so in Australia generally, the use of antibiotics has come down, particularly in some areas. Some specific antibiotics are restricted now for particular infections and can't be used for any type of infection. So that's had an impact as well. The Pharmaceutical Society, with whom I've done some work here in Australia, has also run campaigns to assist pharmacists in presenting to our patients and our clients accurate and appropriate and up-to-date evidence-based information. Lastly, but by no means leastly, the industry partner today, Reckitt, have some wonderful resources, materials that are available through GRIP, through the Global Respiratory Infection Partnership. So you can go to that website and download the resources which you can use in your own pharmacy to present an evidence-based case to your patients. I might say too, for your own information, there are a couple of great videos, animated videos under the name of Bob, B-O-B, Bob, and it's worth having a look at those. They're very amusing and very good, very effective, and you can even show them to your patients as well.
Thank you very much. And John, I'd also like to make everybody, I'm sure all of this audience is already aware of the World Antimicrobial Awareness media and posters that are available on the WHO website. Doug, just to say that your Utah Aware campaign was really good in that you actually looked into the impact of this awareness campaign on AMR, on azithromycin, for example, etc. So there was a measurable way you measured what impact this had. Can I just ask, has it been sustainable? Are you seeing a year-on-year improvement?
That's a great question. Unfortunately, like many programs, we start and we run great for a couple of years, and then things happen. And so we have not been continuing to monitor that. The state of Utah does monitor antibiotic utilization and prescription use so we can collect that data, but not data regarding sensitivity.
Great. So I'm just going to go to the chat because this relates to, there's some comments from George Nonas and Gabriel Mendoza that speak to awareness campaigns or how to ensure that the appropriate use of antimicrobials. So George speaks about clinical governance support with robust frameworks and policy may improve the use of antimicrobials. And he also mentions a traffic light system to allow the use of antibiotics for specific conditions to ensure uniform prescribing. So these would be the treatment guidelines and associated essential medicines list, I would assume. And then there's also the Gabrielle speaks about the options of advertisements or commercials on the appropriate use of antimicrobials with support of the government. I completely agree with all of these, but to get sustainable change, we have to give the same message in innovative ways over consistently, and not just in November when it's World Antimicrobial Awareness Week, so that we have sustained behavior change from the prescribers, from the users, from the dispensers, and the people that the people that administer the antimicrobials in the hospital setting. Virat, you've got a number of individual questions directed to your study in the chat, and I'm going to ask you to please respond to them in writing, if you would. And then I would ask all of you to ask the two questions for each one of you is, what would be your first line of therapy for sore throat? And could you stratify that by adult and child? Number one, that's the first question. And the second question is, besides the point of care test on the strep, what other instruments are available for pharmacists for rapid diagnostics or point of care? And I know that you're coming in from your own perspectives, but it'll be very interesting to hear what you suggest. So Virat, let's go with you first. What's your first line of treatment, adults and children, and what rapid diagnostics or point of care tests are you aware of? Please go ahead.
About the treatment of the sore throat line, what is the first line for treatment of the sore throat line? Yes. Okay, for me, it's the first one. If the patient come in with the sore throat, we will see their sign and symptom, and it may use the Essack score or Centaur score to differentiate. And also, if before COVID, we can picture the throat of the patients, and after that, it's not suitable to see the throat of the patient, right? So after I screening and see that it's infect from virus infection, normally we suggest them two alternative. The first one is like a self-care, like drink a lot of water and rest, and symptomatic treatment is good. And if they still want some medicine, I will suggest like antiseptic lotion or NSAID lotion. That is John Bell say that is good for. And also we suggest them like a Thai herb, Farthalizone. Both of these is effective for in the first line for viral infection that appear the symptom of the sore throat. For me.
Thank you. Doug?
Yeah, I think the first thing that I recommend, number one, with Virat is hydration, and making sure that folks stay well hydrated with water, specifically, not soda or too much juice or anything else. The second thing is a lozenge that can provide relief, whether it is just something to suck on and keep the throat moist so that the hoarseness doesn't develop and the pain of the sore throat goes away. That's fine. And then look at the other symptoms that are along with that sore throat. Does the patient have a fever? Do they have runny nose? Is there anything else that they're trying to treat? And then make a recommendation based on those additional symptoms as well.
Thank you. John, I'm going to go to you, and then I'm going to come back to each one of you to think about what we can recommend for children. So, John, over to you.
Yeah, I'd very much agree with what Virat and Doug have said. Certainly, as I think we've all recognised, that most of the time a sore throat is the very first sign of the common cold. Now, I think if we think that it may be not the common cold, if it's another cause, maybe it's air pollution, it's smoking, it's dry throat for some other reason, maybe it's an allergic rhinitis and postnasal drip, then we should treat the cause. But where we're pretty much satisfied that it's the first sign of the common cold, then of course hydration. I strongly believe, and my own experience tells me, personal experience and with my patients, that a non-steroidal anti-inflammatory lozenge or spray is the best option initially. And if you need an analgesic or even an NSAID taken orally as well, you can do that. The fact that you've got a local anti-inflammatory which works just locally, it's not unreasonable to have the non-prescription dose of something like ibuprofen as well if the sore throat is quite severe. Now, often that will be sufficient to manage the symptoms within a few days and they don't progress. But if they do progress to other symptoms, as Doug has said, then those other symptoms need to be treated, whether it's nasal congestion or rhinorrhea or aches and pains. Then you treat the other symptoms. You treat the symptoms that are most problematic for the patient. In the first instance, that's almost always sore throat. You go with an anti-inflammatory lozenge or spray, in my experience.
And John, can I ask, since you have the floor, to speak about pediatric treatments, please? Yes, well,
they're often a challenge, more of a challenge than with adults. And of course, it depends on the age of the child. I think for children generally, an analgesic taken orally, it could be paracetamol or it could be ibuprofen, and something very soothing for the throat. But hydration is really important. So I think, to me, they're the best options.
Thank you. So Virat, can I ask, the herb that is part of your national formulary, is that also recommended for children?
No, not now for children. It's for adults.
Okay. Doug, do you want to add anything, or are you happy with your the colleagues' responses?
Yep. Well, I think that John and Wera have done a nice job. I would just add the humidification. Now, depending on where a person lives, in a dry climate like where I live, adding a humidifier or a vaporizer to the home makes a pretty significant difference and is very helpful in cold and flu. And then for a pediatric patient, symptom relief that is systemic is great. If the child is not too young and old enough, then a nasal wash is also effective. Just a simple saline wash can be used, and that can also relieve some of the rhinorrhea.
Can I just ask, we've got one question related to hydration in the Q&A. Do you suggest water only, or do you think an electrolyte solution for hydration would be better?
Well, I like water as the first line. An electrolyte solution is certainly a fine second line. I worry about calories and adding too many liquid calories to someone who is not feeling great. So that's my concern with anything besides water.
So we have a question around fungal throat infection and what would be our recommendations for that. I would assume that the throat, whatever type of throat infection it would be, we would have to make sure that it was a non-viral etiology before we recommend a fungal an antifungal or an antibiotic. And I'm not sure that we have point of care tests to differentiate between fungal and viral as opposed to bacterial and viral, which is a bit more focused. So any thoughts on fungal throat infection? How common is it?
Sabiha, often we can detect a fungal infection just by looking at the throat and the tongue. And sometimes that's obvious, and you would use some antifungal drops or solution. But you can, if the throat is really sore, you can still use an anti-inflammatory to ease the soreness, even with an antifungal. Now, if we're in doubt, then we should refer on for testing. But when it's obvious, then the antifungal solutions are usually quite good when used appropriately.
Thank you. Would anybody else like to add to the antifungal question?
For me, for in Thailand, when we not only the fungal infection, but it's sometimes we can meet the case at more severe, like a fungal infection or someone have a HIV infection before, and opportunistic of the fungal infection in the mouth. Normally, I advise him or her to visit the doctor. It will be better to let the doctor to treat is more complication of the sore throat or abnormal and rare case like that.
I agree. I would refer to a physician for a suspected fungal throat infection.
Thank you very much. There's quite a bit of activity in the chat around home remedies and what is advocated for children or adults in that. John, you had Dr. Google tell us what we should and what we can and cannot use, or what the most popular ones are. Obviously, the evidence base is really necessary for all of these things, but the use of honey and lime and all of that is commonplace in most countries. So any thoughts about home remedies, and what is your favorite home remedy? Let's start with Virat.
What in home Thailand, remedy? Yes, for the children, we still suggest the parent to observe their conscience. It's very serious because if the fever is very high, it will be convulsion or complication like that. The first thing is I suggest them to take paracetamol syrup for their home, like a home remedy, because sometimes the patient will have the fever, the children have the fever, or after admit accept vaccine. Some children vaccine have a fever after that. And if want to reduce the fever, in Thailand we suggest like a coat in the water and what to body. Yes, it's good to reduce the fever or reduce the temperature of the children. We use the coach with the water and let it nearly die. And
thank you.
Please.
Thank you, Virat.
Yes.
Doug and John, any thoughts?
Yeah, my favorite home remedy is warm water with honey and lemon. It works great, and it's warm, so it's soothing and relieving.
I actually agree with that. Doug, you took the words, you even took the honey and lemon out of my mouth, Doug. No, I think that's right. But, a home remedy, don't we all have paracetamol and ibuprofen in the home? I think they're home remedies these days as well.
Absolutely. So thank you very much. We're almost at the end. I want to have one take-home message from each one of you. Please, if you had to summarize your take-home message to the pharmacists that are online, what would it be? John, shall we start with you?
Sure, Sabiha. Well, I'd say treat the patient who comes to you, your client, whatever you call that consumer of health, who's such a loyal person to your pharmacy. have a chat with them. Make sure you know what their most problematic symptoms are, and personalise the treatment for them. There's the kind of, I don't know whether you'd call them home remedies, but self-care actions that they can take, like Doug mentioned, humidifying a dry room, making sure that they're well hydrated, resting if they possibly can. And then I would choose a product which I think is going to be best for their particular symptoms. If it's a sore throat, I would be going, as I mentioned earlier, for an anti-inflammatory lozenge or spray in the first instance.
Thank you very much. Doug, over to you.
I think my take home is that sudden onset sore throat with a high fever and tonsillopharyngeal edema is probably bacterial. Everything else is probably viral. And self-care treatment, whether home remedy or an over-the-counter therapy to relieve symptoms, is totally appropriate.
Thank you very much. And Virat, your take-home message?
I want to let our pharmacists around the world know that when I just graduated from the Faculty of Pharmacy about 40 years ago, in that time, we learned that sore throat is a cause from bacterial infection. 40 years ago, new knowledge tell me that it's not cause born or from viral. Its major cause is a viral infection. We change our knowledge, and also I want to tell our pharmacists around the world that my patients at the first, I suggest them they some resistance. It's my challenge. I like the words of the doc that teach community. We must to teach community to the best use of antibiotic for sore throat.
Thank you very much. Chris, can I ask you to share the slides, please? So we end up, so thank you very much to everybody for those excellent take-home messages. I want to just go through to say our next, Chris, the next slide, please. Yeah, okay, great. So our next episode in the self-care series is gastrointestinal complaints and treatments, which is going to be on the 2nd of December at 11 to 12:30 Central European time. Next, please. And then we want you to check all of the future FIP digital events at this website. There are lots happening, and especially during this week, there's lots on AMR and appropriate antimicrobial use. If we go to the next one, please. We'd like to thank Reckitt again for supporting this online program and the whole online series. You will agree with me that this has been an outstanding session. We've had phenomenal speakers who shared their practice experience, educational experience, their academic experience, and it's been an invaluable learning experience for all of us. We special thank you to all of the participants. We had more than 250, and I know several more are going to watch the recording of this. I'm sorry we couldn't get to all of the questions, but some of them can be answered in writing. So we're really very grateful for your contributions and your questions. And despite the little glitches, a very special thank you to Myla, to Chris, and the team at FIP. Your technical support and attention to detail makes it very easy for us moderators and speakers. So thank you very much, everyone. And we'll see you online and on the screen for future events. Thank you very much. Have a good day further.